Yes, I can invite the panel to take their seats. While they are assembling. Calypso, are you still on the phone?
Yes, yes, I am.
Great. If you would, please, as you begin to formulate your questions, there are microphones. Dr. Newcomer looks like he's about to take advantage of that. So please speak clearly and with volume, and particularly if you're addressing a question to Calypso, and I will try to repeat the question as well. So, Dr. Newcomer, we'll let you start us off.
Thanks, Barry. Lee Newcomer, United Healthcare. So, Yusuf, I want to introduce you to my two kids, both in their upper 20s. One of them works here, U.S. Congress, gets paid $30,000 a year. He's saved $5,000 already in his 3 years of work. His sister lives in New York, works for an Ivy League college, gets paid a lot more than that, and is penniless. In fact, she barely can make her credit card payments. She's the typical American. My son is probably Japanese based on the way he saves. So here's the question. Is this really a cancer problem, or is this an economic problem that Americans aren't willing to put enough value on healthcare to save for it? And how do you contrast those two? And I guess tie into that, why isn't $360 a year worth living longer for breast cancer? You showed a very good slide about how rates drop and people don't use their aromatase inhibitors. So talk to us a little bit more about the value that Americans see in healthcare in general and why cancer is unique.
First of all, I'd like to congratulate you on your Japanese son. He's making some progress there. You know, many of us in the room were at the American Society of Clinical Oncology meeting last week, where there was a great deal of discussion around that very topic. So what is the value of healthcare? So, I mean, to answer your first question, I would say, no, I don't think this is just a cancer problem. I mean, I think a lot of this has to do with our culture. In this country, I think we are very reluctant to say, to assign a boundary to how much we are willing to pay or should pay on healthcare. And I think that's potentially created some of the problems. As I'm talking, I'm veering into a territory that I would rather not be talking about on record. But it is a very important point. What I'm really happy to see is organizations like ASCO talking more about value and maybe assigning a value rating to some of the treatments that are out there to better understand, to help patients and providers better understand what is valuable care. So yes, I think this is beyond just a cancer issue and is more of a cultural issue.
Yusuf, some people though would suggest, you know, that patients need to pay more, that they don't pay enough, and that's what's producing a lack of calibration on value. And I would bring Mark into the conversation, the suggestion that with Medicare secondary insurance that Medicare patients are immune from the cost of care. So, you know, there is a contrary argument that actually patients aren't paying enough.
So I think we're talking a little bit about value-based insurance later on today, but I cringe at the thought of patients who've just been diagnosed with a life-limiting illness having to have more skin in the game. Yes, I think many of our patients are protected from certain costs of care, but I'm not sure that cancer treatment is the right focus for introducing patients to cost, particularly at that time in their lives.
Mark, you were going to say something?
Yeah, I just wanted to say I think I'm already in enough trouble. You're not dragging me into this question.
I thought I would try. Peyton, you actually founded a company that is a leader in this area. How many patients actually go without care, or I mean, what's the magnitude of this issue?
It's a huge problem. And I think, we touch on a couple of issues here. I would agree with Yusuf that, this catastrophic issue, this out-of-pocket max is probably the mechanism that most of us feel like we share costs, but then as a society, there should be a max to some extent where you're not faced with those decisions. And the patient that he highlighted today, though, I think is particularly useful, though, for the debate, particularly now that we have cancer therapies that are oral therapies. So that patient did not have prescription drug coverage, obviously something that, an unevenness in coverage, if you will. I tend to have better benefits for myself as I move into a more acute setting. So my best personal coverage is in an inpatient setting, then the physician office setting, and my highest copay is actually on my drug coverage. And so I think we need to look at some of those pieces because it's very cost effective to have that oral product. You want patients to have access to that and not be making treatment decisions on that and have a broader view, right, of that coverage so that we can make the best decision. So, he highlighted a really important challenge that we have from a patient access perspective, and that's those gaps in coverage and uneven levels of out-of-pocket maximums. And that's what creates patients that then appear to us to me be not just uninsured, that's one segment, but underinsured. And that's really where the crisis is.
So a couple of points for you to respond to. One, even if the cost of cancer care was halved, it would still be out of the reach of a patient's ability to pay. And Dr. Newcomer, some of the insurers in the room the impact on maximum out-of-pockets might not be affected appreciably either. So, Dr. Yusuf, what practically, what are the implications of what we might actually do to change this?
So on my list near my end of my talk, I was sort of discussing what we could do. One thing that you didn't see on that list was lower the price of treatment. I feel like a lot of the things that I talk about end up being sort of Band-Aids to a larger problem of a sort of upward spiraling cost of care. Until we can get prices under control, though, I think the Band-Aids are what we have closest to our reach. So, I think encouraging communication around costs is a first and fairly easy step. But I also think, including our patients in this value discussion really will have a immediate benefit. We don't, as an oncologist, I'll say I don't do a very good job of educating my patients on the value of the treatment they're getting, even though cost and communication is a really important part of what I do. I bet if you talk to one of my patients immediately after they walked out of the room, they probably wouldn't have a very good idea of exactly how much life expectancy or quality of life they're going to get out of this very expensive treatment I'm giving to them. And they probably don't have a very good idea of how much to expect in terms of that treatment either. So I think including patients in this value proposition is an important first step.
You're suggesting that if patients were informed consistently of the outcomes and risks that they might make different choices?
Yeah, absolutely. So we're designing a really interesting study right now that's looking at sort of gambling tendencies of patients and their providers. And I think if we understand how patients make decisions and what they value, we might have situations where patients decline treatment. I mean, I had a patient with advanced pancreatic cancer who, as a part of his decision not to receive treatment, he said, I know I have crappy insurance, I know I'm underinsured, and I know my family is going to end up with thousands of dollars in bills after I've died, and I don't want to do that to them.
Dr. Gould, have you seen your operational behavior in regard to patient liability change over the last few years?
I guess in regards to what's germane to this overall conversation, as part of our practice, of course, we're not subsidized by larger institutions, so we have to be clear in terms of what our expectations are with the patients and whether or not we're going to be able to collect, their co-pays from them, and if not, then we have them speak with the financial counselor. And a lot of, I guess, the administrative burden of our practice is really getting these underinsured or uninsured patients access to care through copay foundations and foundations that supply free drug and so forth. So our patients always, again, have the opportunity to speak with a financial counselor so they know what the expectations are. And if there's an issue, then we can intervene and change the therapy before the patient's hit with thousands of dollars in drug fees.
Let's put a new question on the table.
Okay, Wendy DeMark from University of Alabama at Birmingham. And I was interested, Dr. Gould, you might as well keep your microphone on, in your slides as far as discrepancy between the hospital-based versus the private provider. And just wanted to get a little bit clarification, just because people that do tend to receive their care at a hospital setting may have more comorbidities, may have higher stage, and just wanted to know if the statistics that you presented were corrected.
Yes, I mean, in the 4 studies I alluded to and presented, all those were risk adjusted for those various factors that you just mentioned, because obviously, if there was a difference in the site of care, that would be the first thing that people would raise. So in order to have a valid study, those things were adjusted for.
Thank you.
Are these questions here? Are you guys waiting in line? Okay, just wanted to prioritize. All right.
Rich Shilsky from ASCO. I guess I wanted to return to the prior topic again for just a minute with a question for Dr. Zafar. So in your little study that you showed us at the end there about what physicians do when they do have a conversation with patients about cost, 75% of the time what the physician did was to try to obtain financial assistance for the patient, which of course is a cost shifting maneuver, not a cost reducing maneuver. And rarely did the physician actually do anything to change their practice to help reduce the cost. And that, to some extent, is illustrated by your own anecdote about your own patient, where whether you discussed with him the cost of treatment or not, you still chose a far more expensive therapy for him when you had an option to prescribe a less expensive regimen. And you didn't tell us why you chose the regimen you chose. But I guess my question is then, what can we do to help, guide, incentivize physicians when therapies of equivalent efficacy and similar toxicity are available to in fact prescribe the less expensive regimen?
So I think, getting into a little bit of the details of this, capecitabine versus 5-FU choice, it's, there's more than cost there, obviously. There has a lot to do with patient convenience and preference and potentially side effects and things like that, as you know. But I just wonder if awareness has a lot to do with it. I mean, you look at data that show that 1 out of 3 patients are struggling with their medical bills. I doubt that if, I asked my colleagues at my institution, how many of your patients you think are struggling with your medical bills? I doubt they would say a third. We care deeply about our patients. We want to make sure that we're giving them appropriate care. I wonder if a lot of this has to do first with just lack of knowledge about what our patients are struggling with, and second is discomfort. There is a great deal of discomfort in terms of talking about costs, and I think that's another barrier, and our study showed it's a main barrier to having these cost discussions. So what your organization is doing is bringing cost and value to the forefront. So every discussant of every major research presented at ASCO was asked to talk about value. And when you start doing things like that, it comes into the mainstream, the lexicon of what we do every day.
Dr. Gould, a lot of folks are talking about how to incentivize you differently at this decision point, or control, or to limit your decision-making ability. I mean, what is the physician's perspective on this external influence of your decision with a patient?
Well, physicians are like most people in that we don't like to be told what to do, but unfortunately, I think that's the reality. And I guess the first, foray into trying to standardize physician practice is the increasing use of guidelines. I mean, it started off with the NCCN guidelines, which is, a very broad-based number of regimens that can be used for any particular illness. But, there are other entities out there that have narrowed those guidelines significantly. And as each payer has adopted those guidelines, it's becoming more and more burdensome for the physicians to remember what guideline goes with what patient. Our practice administrator jokes that when the patients come in, they're going to be given a hat with what payer is paying their medical bills so that we can, get the right guideline and, have it in our face in terms of who their payer is so that we match the guidelines and the payers together. As part of the Community Oncology Alliance solution to this problem is we look at the total care of the patient and not just the drugs. And that includes providing care in the lowest cost setting, which is the physician's office, as well as trying to limit the use of high dollar resources like hospitals and chemotherapy at the end of life. So again, I ultimately see medical practice evolving to the oncology medical home model where the physician takes responsibility for the total care of the patient and being more thoughtful in the use of our limited resources.
Next question.
Thank you. Martin Murphy from the CEO Roundtable on Cancer. And Barry, this question is directed, if I may, to you, but also I'd like to involve Yusuf. Your slide, actually two slides you showed. One was a comment about WellPoint and the $350 per month per patient offer if an oncologist uses what might be described as their schedule. And then another slide was those practices throughout the United States that are either in jeopardy, presumably financial, or that have actually declared bankruptcy or gone out of business, those dots in red. And the migration from private practice into hospital practice being largely financially driven. Does anybody in the panel, but Yusuf, I'd be especially interested in your comments, have any concerns about that? Do you see drawing these financial realities, challenging financial realities in the private practice of oncology being impacted positively or perhaps negatively by a situation in which a provider, a insurer, is now offering an incentive? And then I have a very brief rejoinder for Yusuf. Thank you. Go ahead, Barry. Yes, Bruce.
Oh, okay.
I'm sorry. Excuse me.
So, obviously it's a big concern to the patients. I think, all this change in the site of service is resulting in clinic closures, which is increasing the logistical toxicity to the patients are having significantly higher out-of-pocket costs, which is contributing to the financial toxicities. And it's not just, in our market, it's not just the average of $134 per chemotherapy treatment session. I mean, many times it's hundreds, if not thousands of dollars. And, in our practice, however, we're still community-based and we've been able to benefit because all our competitors are now hospital-based, and so patients, are shifting their care to us because we're the lower cost provider. And I guess, thirdly, the concern from the patients is, what kind of care are they going to get through a, hospital-based organization, which is more bureaucratic in nature and maybe less focused on the oncology service line than what a private practice would be, where that's our only line of business. And, we spend, all our time thinking and trying to improve our services. So I suspect not only is the cost of care going to be lower in the physician practice setting, but the quality of care will be better as well.
I mean, from a provider perspective, I see this as, practicing at a major cancer referral center. It used to be we were the sort of lumbering beast in the area where it was impossible to get people in and we were inefficient. But now patients are so impressed at how quickly that we can see patients. A lot of that has to do with when they go back to the community, they have long wait times. They have to travel even within the community to go to practices And I think a lot of that has to do with what Bruce talked about in terms of consolidation in practices.
Thank you both. Yusuf, the rejoinder was, could you let us know about that, your patient, and the reason why he's standing by a fighter jet, and if those heat-seeking missiles had any particular coordinates on payers versus et cetera?
Next question.
Hi, good morning. Thank you. I'm Cindy Gagan. I'm a breast cancer survivor and a patient advocate. And I just wanted to bring the patient perspective, and I know Dr. Zahar, you did as well, but about this culture of, cost sharing, et cetera. And I think cost is kind of the new C word for patients because it's not something we knew about and we were aware of. But I also wanted to kind of bring a broader cultural context because I was also at the ASCO meeting and the other 90% that wasn't talking about value was talking about innovation and all the promise of these new therapies. So I think when you look at the public and what their expectations are, it's that we're going to cure this thing and that they're going to get newer, better, faster treatment. And this is a tough kind of conversation to have. The cost we all understand, but how do you kind of balance this kind of conversation with our need for more research to participate in clinical trials, et cetera?
So that's a really important point. And Jeff Peppercorn, who's in the audience, and I have talked a lot about this. And we're actually oftentimes making the argument that, yes, we talk about spending too much on cancer care, but in reality, maybe we're not spending enough. Maybe we're not spending appropriately. And I think that's an important discussion to have as well. Go ahead.
No, I'll just add on to that. I mean, first of all, thank you for bringing the patient perspective to the discussion because at the end of the day, that's all that matters. We can't talk about access without talking about patients. And I think we've got a challenging situation. How do we incent and reward value, right? So keep affordable sites of care, affordable access, incent that value, but at the same time, incent innovation, right? So we need to be careful to avoid some of the unintended consequences and hopefully to give also CMS the tools to be able to have things that incent value, but in no way create price controls or things that might, otherwise really damage that next level of innovation that ultimately could actually reduce costs for the long term or dramatically change patient outcome for the long term. So that is the balance I think we have.
Mark?
Yeah, so I'd like to add to this discussion. So I think what was probably clear from my presentation is that care has shifted where incentives have shifted. So when there was a lot of shift from the outpatient to the physician office under a particular pricing methodology, and then when we changed that pricing methodology, care is shifting again. And then the presentation ended by looking across sites, like how we pay under the physician fee schedule versus how we pay in the hospital outpatient department for a particular service. And I think Dr. Gould mentioned in passing bundling or packaging type of payment methodologies. That's really delivery system reform, which I am not working on directly, more tangentially, but looking at payment models to try to improve quality of care as well as manage costs. So those are some of the innovations that are being adopted because of the Affordable Care Act. So accountable care organizations, the bundled care payment initiatives where we're looking at hospital care, post-acute care, episodes of care. I'm not exactly sure how it's happening in the cancer world, but I think there are two major, I think, reforms that are being looked at. CMS MedPAC looking across sites at how we pay for care in the individual benefit category or the individual site of service, but then these larger delivery system reforms trying to integrate all of the different types of providers that provide care to a patient to coordinate those patients' care at a bundle or one single lump sum large payment that provide incentives to manage the patient's care and provide quality incentives as well.
Calypso, let me bring you into the conversation. Hopefully you've been able to hear the questions. Do you have any observations or comments at this point?
No, I think it's all fascinating, really. I think
very similar questions we're faced with in the UK as well. I guess the system is slightly different, allows us to have a conversation at a different level, but it's the same issue. So, no, thanks for allowing me to be part of this.
Calypso, you made a statement at the beginning of your presentation to the effect of that the U.S. market is doing us a disservice by being too lenient. With this comment by our patient advocate about balancing innovation and the need to progress, how would you respond to the suggestion that the U.S. market is bearing the burden of what are rather fixed costs to this point of progress in cancer care?
Well, I think the issue is sustainability, as people have said, and it's sustainability right here, right now, whether individuals, patients, households can manage the escalation costs when they're hit by the disease. So we need to think about the now and the access, as much as we need to think about sustainability of health systems and the sustainability of an industry that is an innovative industry and that's doing a lot of good. So we're all starting to doubt whether the current model of innovation is sustainable. And of course, the question then becomes if the model needs to change. Sustaining the current model, even though we know that in the medium term we won't be able to continue doing so, is not the answer. So it's difficult, of course, to change. And, individuals go bankrupt, countries can go bankrupt too, or have accumulated immense debt. So ideally, one changes or triggers change before the terrible situation of bankruptcy, whether at the country level or the individual household level happens. So what I'm trying to say is innovation is important, but it has to be innovation that we can afford. If health systems can no longer afford innovation, then two things will happen. Patients right here, right now will suffer because they won't be getting access to the treatments they need. And patients in the future will also suffer because health systems will cease to fund innovation the way we've known it. So something has to give. We can't just continue innovating at a cost that's unaffordable.
Dr. Kaloje is a medical oncologist and now with Aetna. I'll bring you into the conversation.
Thanks. Thanks, Barry. So Mike Kaloje, National Medical Director for Aetna doing oncology. So, I think omeprazole is a great drug, and I'm pretty sure that if I had candy bowls in my house and I put omeprazole in every one, Aetna wouldn't care. And the reason wouldn't care is because the unit cost is so low. And we haven't really talked about unit cost. We've talked about innovation. I would suggest that's a false argument because innovation is a very subjective term. So here's my question, and I'd love the input from the nice person. The nice person and the nice person. Why aren't we ready for non-binding health technology assessment? Why aren't we ready for Medicare to actually negotiate price of drugs? Why aren't we ready for real comparative effectiveness research that allow us to get a laser focus on what's quality? Why aren't we ready for that?
So we'll let Calypso comment on that, but then I'll let Mark comment or not comment, whichever you so choose to do. Calypso?
Yes, well, it's a good question. I don't know. I don't have the answer. It is a very good question, and I think clearly the United States market, the way you regulate pharmaceutical products, the way the FDA sets standards, the way CMS pays, and the way your private insurance pay influences the whole of the world. So certainly what you do will have a huge impact on what others do, both on the supply side and on the payer side. So why aren't you ready? I don't know. To me, it's perplexing. The United States is a country that supports free market, supports competition, and here we have a pharmaceutical market that's far from being a functional market. And I think there's a couple of things that payers can do, including putting information out there in the public domain and using this information to inform their own choices as to what they pay for. And these things are not at all our sort of taboo issues in the United States. So I don't understand, but it's still very important, of course, to try and answer this question. So thank you.
Mark?
Yeah, so I guess the first thing I'm going to say is I'm not having any candy at your house.
If you have reflux, it'll help.
Unless I have the appropriate diagnosis. So I think so this is where I always like to say, I don't tell you what should be, I just tell you what is. And the reason we don't negotiate prices is because we have a prohibition on the law that doesn't allow us to negotiate prices. We always follow the law. Although people are always challenging us on whether we're actually following law, because the number of lawsuits that we have at any particular moment is probably more than there are people in this room. So I guess I had a thought that was going along with it. Oh, yes, the other issue that comes up from time to time is non-interference with the practice of medicine. So if Title 18 of the Social Security Act is the title that establishes the Medicare program. And I think if you look at probably like the first couple sentences of Title 18, it says nothing in this provision of statute should be construed as to allow the Secretary of Health and Human Services to interfere with the practice of medicine. Now, I think that's very debatable whether some of the policies that are in the rest of that statutory provision, regulatory provision, which certainly influence the practice of medicine, but there is that we do come back to that from time to time, where we have what I guess on Star Trek would have been called the Prime Directive: do not interfere with the cultures that you're going to, and then they go ahead and they do it every time on every show. I'd like to think that we're not doing that every time we make a decision, but we are at least cognizant that there's a provision that certainly precludes us from interfering with the practice of medicine, and then certainly very directly precludes us from negotiating drug prices.
Peyton, your companies consult with the pharmaceutical industry as well as providers, but both sides of the care continuum. The Affordable Care Act specifically prohibited the use of QALYs or ICER or other metrics specifically that engaged with survival from inclusion in some of the new programs. What is the argument against these things?
Yeah, I think the challenge is, how do we bring in the free market system and not create this law of unintended consequence, which feels like where we are today, actually, where we didn't intend to shift to higher cost of care settings. We didn't intend for any of that to happen, but it's clearly happened, as the data showed today. So, how do we balance that? I'm optimistic about some of these bundled payment initiatives. They certainly sound exciting in terms of being able to move us forward, and I think ASCO's done a fantastic job by bringing value into the discussion. And I think the hard part is we're in the infancy of these discussions to a large extent. We're not where we ultimately will probably end up. We're at the beginning of that discussion, and it's very difficult when you talk about oncology, actually even compared to other disease states, because of the difficulty related to the outcomes, because of the impact of side effects and how it actually impacts the efficacy of products if you can't complete treatment. So it's a tougher one to solve, which I think is why we're all struggling with that. And how do you balance all of these components so that we can get to those products that really do drive to an even better result from an outcomes perspective?
Dr. Ward is a practicing oncologist and has led ASCO's clinical practice committee in other ways in the development of their model. Welcome to the discussion.
Thank you. My question is predominantly for Mark, but Bruce may want to weigh in too. I'm one of those oncologists that has made the transition from private practice into a hospital-based setting. I was glad to hear that CMS will take responsibility for a misapplication of an underpowered and poorly executed survey to help hasten that move. I'll note that the probably cardiology, as you noted, really led the way in that. But I am concerned that there seems to be a perception that all that has to happen to make that transition is that you sell your practice within 35 miles of a hospital and flip your shingle from independent practice to hospital outpatient. There are clearly requirements that are necessary from a facility standpoint to be able to bill as a hospital outpatient department, whether you're 340B or not. And I get the impression that either those requirements are sometimes being ignored or we're glibly thinking that it's easier than it is. Does CMS have a sense that that people are inappropriately billing as hospital outpatient departments without making the facility changes that are really required to do so?
Yeah, so I appreciate you bringing that up because I don't really know. I mean, the impression that I have is, I mean, I think the question you're asking is whether there is well, I don't know exactly what question you're asking, but whether we have the resources to do surveys to look at these sites. And I think the answer to that is we generally don't do surveys of them. I'm not sure exactly what requirement. I mean, they have to be a provider outpatient, hospital outpatient department, which means that they have to meet the conditions of participation, and they're certainly at risk if there is a survey done and they don't meet those conditions of participation. If they attested that they met those requirements to be a hospital outpatient department, and then were found not to meet them, then they would be liable for payment recoupment for the difference between what we would pay under the physician fee schedule in the hospital outpatient department, retroactive to the date of the attestation. If there's no attestation, they could be retroactive until the date they actually started billing as a provider outpatient department. Yes, it's correct. You have to meet those requirements. The level of enforcement, I think, is certainly a reasonable question to ask, and I think that's really more a question of what kind of resources does CMS have to be able, CMS and its partners in the states and the quality improvement organizations and the Joint Commission have to actually go out and do those kinds of surveys. But I think one thing that's clear is certainly practices have been moving towards the changes in payments have shifted the incentives, and many physician practices have become hospital outpatient departments. I cannot concur on your comments about the PPIS survey, or as you presented them, other than to say the survey was done by a multi-specialty organization. The physician specialties contributed the financial resources. The AMA conducted the survey, and CMS used the survey. The survey has certainly been subject to significant criticism about the number of surveys, its precision, and so forth, and resulted in, I don't know that CMS itself has acknowledged those shortcomings.
Mark, at least 3 times folks have noted the influence, if not dominance, of CMS in the marketplace. So the relationship with private payers, the relationship with the setting pricing of drug, and Calypso has even noted that CMS specifically, she had said, influences the world. What is, yeah. Thank you for coming today, Mark.
Great, thanks, appreciate it.
The question pertains to CMS's ability or its processes for self-awareness and studying cause and effect of its policies. Can you speak to that at all?
I suppose I could.
All right, good.
I'm just not sure how. So we are certainly aware that private insurers will adopt our payment rates for a number of services. My reaction to that has always been Medicare is a program for the aged and disabled, and our population is certainly unique in that it doesn't have the variety of patients that private insurers have or that Medicaid will have. You know, Medicaid probably being more oriented towards families, elderly adults, women and children, child health insurance program in particular. So it always concerns me when people come in and say, well, Medicare didn't establish a price for that service, or Medicare established a price for that service, but that service is, the price for that service doesn't allow us to be able to stay in business, but we don't serve any Medicare patients. All we serve are Medicaid patients and private pay patients, because our payment rates are going to be based on information that we have available to us, and in particular, utilization data. And that utilization data is going to be for a 65 plus and disabled population. So it's going to reflect the information that we have on those types of patients. It concerns me that Medicaid or private insurers may be using those rates when they may not be applicable to the types of patients that they have. So just as an anecdote, The DRG system, the Medicare DRG system, used to distinguish between pediatric patients and adult patients, so patients under 18, patients above 18. And we had extremely low utilization for those diagnostic-related groups that were in the pediatric population, not surprisingly, because the only patients we probably would have in the Medicare data would be pediatric end-stage renal disease patients, and probably not a lot of those. So what we call the relative weights would be highly unstable from year to year because you might have had 10 cases or 5 cases, and the costs associated with those cases, the way we determine payment would be, charges and costs would be highly variable. And so then people would be coming to us and saying, you know, that this is really a difficult situation for us as a private insurer or as a Medicaid insurer because we don't know how to pay for these patients. We're using your payment rates. And I would always say, well, don't use our payment rates. Establish payment rates based on your own data and your own patient populations. When we went to the Medicare Severity DRG system in 2008, expanded the DRGs from about, I don't know, 538 to 700 and something DRGs, we got rid of the pediatric differences. And I have to say it was a great idea because these complaints completely went away. Now, I don't know that if private insurers and Medicaid are using the MS-DRGs or not. I suspect they may be. I don't know if the payment rates are applicable to their patients or not, but at least the instability associated with the pediatric patient rates that we were calculating have gone away. So I really do always encourage. So one of the reasons I encourage private insurers and Medicaid to set their own rates is because I just don't like being responsible for somebody else's patients. Particularly don't want to be responsible for what's happening outside the borders of our country.
I will happily fill the void if there are no questions from the audience. Dr. Bach used the term "Me Too" in his illustration. Let me ask the panel, Me Too's have been rare in oncology in either a literal or a categorical sense to this point. My question would be for Dr. Bach and for the panel, is having a Me Too not a requisite for competition and eventually price competition, as well as to Peyton's point of eventually leading to a place where at the end of patent lives there are multiple manufacturers, and we know that when there are 3 or less manufacturers, that's when the drug supply becomes fragile. Is Me Too not a good thing, Dr. Bach?
Well, thanks for asking the question. So in that example, I use Me Too in the colloquial sense.
Sure.
And you're absolutely right, as you know, of course, that it is extremely rare in oncology, even if a drug has the same route of administration, the same indications in patient population, the same mechanism of action, and in many cases grows on the same, out of the same platform for drug development, for it to be treated as unique in the regulatory sense as sole source or in the FDA sense. And that allows it to get, if it's a physician-administered drug, its own pricing code, leading to its own ASP. And if it's an oral drug, it allows it to be protected in a protected group. And we saw the slide about Part D drugs. The same is true for private insurers. Every one of the drugs needs to get covered based on laws or regulations. Same is true at the state level. So the example up there, those 2 drugs, Alcori and Zycadia, are viewed by the entire regulatory apparatus in the insurance, private insurance world as completely different. But I'm just a dumb pulmonologist, but in every other sense of them, they are quite similar. Same mechanism of action, same targeting, same diagnostic test, although the paired diagnostic listed on Xalcori's label isn't on the Zycadia label, the category of cancer is. So there is sort of this open question that you've asked that I wasn't even getting to in my slide, which is, shouldn't these things be competing on price? And the answer is there's no mechanism for that to occur. That's quite different from the omeprazole example, right, which has its competitors. So there's no way to get from where we are to more rational markets without that kind of competition taking place when Me Too's come along, and we can't get to a place where we categorize things as Me Too's as long as the entire regulatory apparatus classifies essentially every new drug for cancer as its own special thing. For what it's worth, I put up that slide obviously to try and wake people up, but also if you looked at the lines in that slide, and I didn't dwell on it, they are essentially every single one of the industry's arguments for why drugs have to cost more. The drugs are efficacious, they were similar efficacy, we've mitigated side effects. They have the same side effect profile. We have to spend a huge amount going into new ventures. Well, the first drug did, the second drug didn't. We have to work with industry to develop a paired diagnostic. The first drug did, the second one didn't. We spend a huge amount in R&D. The first drug had more patients and more studies than the second one, and so on. And yet, at the end of the day, the second drug, the follower, costs more. So I put it up as a way of sort of framing a discussion about, okay, fine, those are the arguments. Here's the counterexample. Please explain. So that's the essay question, I think, for the rest of the day.
Sure, absolutely. Thank you, Peter. Any comments from the panel?
So just briefly, I think you made a really important point, and Rena Conti, who's here today as well, speaking later, had some really interesting data at ASCO this year, which showed the single greatest predictor of price of a follow-up drug is not effectiveness and toxicity or anything like that. It's the price of the drug that came before it.
And I would just add, this is the challenge probably for the rest of the day, so I won't, belabor it at this point, but we do need that kind of competition. We do need systems that allow us to be able to have products compete on value and bring others then into that market so we can continue to evolve. And you're right, the dictator of price shouldn't be the product that first launched. It really should be the value of that product.
All right. Any other questions from our audience? All right. We will end at this point, a touch early, and go to break.
Break, and we'll start the next session at 5 up.
Thank the panel. Thank you, Calypso.